everyone to the Addiction and the Family International Network webinar number 29, as I found out. And of course, I would like to thank to all people who made this possible, especially Richard Wellerman, but also Emmy Kaupila, Sari Yobansu, and Janne Takala, who are providing the technical support. Without the webinars wouldn't be possible. And as you have been notified by email when you registered, AFINet is a small charity. So if you feel you would like to contribute, we would be very happy to receive donations. And I also would like to announce that this year we have an online conference in September, on September 19 and the 20th, where also all members are encouraged to submit abstracts so we can get an overview on what's going on in the international research and treatment provision for affected family members. And it's a great pleasure to welcome Barbara McCrady. Barbara is a distinguished professor of psychology emerita and former director of the Center of Alcohol, Substance Use and Addiction, CASA, at the University of New Mexico. She received her Bachelor of Science in Biology from Purdue University in '69 and her PhD in Clinical Psychology from the University of Rhode Island in '75. And I'm quite sure that all of you have heard of Barbara's work before. She's internationally known for her US National Institute of Health supported work on empirically supported treatments for substance use disorders. And she did a lot of research on cognitive behavioral treatment programs and has developed and tested a conjoint treatment model for persons with substance use disorders and their spouses. And she has also brought scientific attention to Alcoholics Anonymous. And we are also very happy she contributed to the AFINet handbook, which hopefully will be published in autumn this year. And she did a lot of research on treatments to integrate 12-step and couples therapy, and research on mechanisms of change in family-involved treatment and 12-step oriented treatment. She also did a lot of research on women affected by substance use disorders and currently is working on mechanisms of change in recovery from alcohol use disorders, and has a tremendous publication list of more than 250 papers that have been on peer review, books, book chapters, and commentaries. And she has served as primary mentor of about 40 doctoral students in psychology. And she also is not only doing research, but she also has an extensive background in direct clinical services to persons with substance use disorders, and has been active in creating and directing outpatient programs and liaison services for inpatients and a program for impaired professionals. And today, she will be talking about conjoint therapy and the effects on the problem user and the affected family members. And I think the talk will be about 45 minutes, and afterwards there will be opportunity for debate. And if you have got any questions, feel free to ask them in the chat. And the floor is yours, Barbara.
Well, thank you for that lovely introduction. I'm tired just listening to it. I want to particularly thank Richard Velleman for inviting me for this presentation. And just a shout out to Jim Orford, who has been such a important influence in our field of families and addiction. We all go back a very, very long way. My work is not exactly what AFINet is. Let me just put my disclaimer out at the beginning. My work is really focused on bringing families and affected by addiction and the person, identified patient with the addiction together. And so I'm going to be talking about that work and some of the qualitative work that we've been doing as well related to these issues. I'm happy to answer questions at the end. I am really inept in Microsoft Teams, and so if you want to ask questions during it, I probably won't see them, but if you have a burning question, you can just unmute and ask it so that I can hear well, even if I can't necessarily see you. I'm going to talk really about three major areas. First is some of the qualitative work we've done to understand families' perspectives about addiction and the idea of being involved in treatment with their loved one. This work is probably going to be familiar in terms of what families have had to say, very familiar to this group, but it sort of sets a stage for some of the other work that we've done. I'll probably spend a lot of my time giving you an overview of our couple-involved treatment model and some of the outcomes, and then delve into some of the coding work we've done with therapy sessions. I have only done one process coding study in my life, and that was enough. But it's fascinating to actually sit and listen to what people are saying in the sessions and try to code it and make sense out of it. So I'm pretty excited about that, about this particular work. And then I'll give you some summary and conclusions and some looking forward directions. But first, a brief historical note. Probably almost 20 years ago, I met Richard for the first time at a conference in Santa Fe. And for that talk, I really looked at the history of family-involved alcohol treatment. I'm now 20-some years later, now that I'm retired, I'm finally getting around to writing up the paper, but fortunately, history doesn't really change. But it's fascinating going back, even to the 1600s, to see how much, 400 or 500 years ago, professionals really recognized how desperate families are when they're affected by alcohol and drug problems. And professionals, even in the 1800s at least, we have good documentation of ways that they would involve the families in the patient's treatment. I'm not going to go into a lot of that because it's a whole talk in its own right, but I just had to include one example from a book from 1889 in which Kerr described a man whose wife was, the term then was an inebriate. He was desperate to get his wife to change, and he decided he would just cover her with black paint when she was passed out after she'd been drinking. And then when she awakened, he implied that this had something to do with her drinking, but she thought she had a terrible disease. And he kept doing this over a month's time. And finally, she became sober. So what we do today, of course, the interventions are quite different, but the concerns are there, and the desire of family members to be engaged with and try to impact their family, their loved ones drinking has not changed. Oh, I have a different screen now. Yay, thank you. I want to now move into some of the focus group work that we've done to really hear about what families are saying today about the impact of the loved ones drinking and what they think about the idea of being in treatment. We conducted some focus groups with families of individuals with alcohol or other substance use disorders. We also did focus groups with identified patients. I just lost my entire screen. Somebody did something.
We have just also lost the share screen as well.
The share screen just went away.
Yeah.
Did it go away for everybody?
Yeah. It's gone away for all of us.
Should I try to upload the presentation from my computer? It's Janne speaking. My camera isn't working.
Yeah.
Okay, I didn't even do anything. That was
if you could, I'm afraid, Barbara, it's going to mean you saying next slide, please, when you want it. But is that going to be okay?
That's fine. I can do that.
Okay, so yes, please, Jana.
Okay, so as it's coming up, we interviewed both, we did focus groups with family members, with identified patients, and with professionals in the substance use treatment field. And we asked them a number of questions about their perception, particularly so with the families, how addiction has impacted them. We asked them what they thought about the idea of being involved in treatment with their loved one. And then we went through a very, I don't have a screen yet, we went through a very extensive coding process to make sense out of the narratives that we heard. So at the beginning, we simply had 3 people listen to the tapes and generate initial ideas for codes. We did some consensus coding at that point. Yes, thank you. All right. Next slide, next slide, next slide, I think. I think it should be about the 4th slide. Next one, next one. Okay, wait, go back one, just. Okay, how the problems affect and their thoughts about being involved in treatment. And we also asked them about their perception of barriers to involvement. The next slide will show how we coded the tapes. That was next slide. I'm gonna try to be smooth about this. And we use this grounded theory approach to analyzing qualitative data. Some of you may be very familiar with it. But you just listened first, tried to identify some themes. Then we coded one recording by several of us to refine the themes and the categories. And then we did coding of all of them to finalize the themes, the categories, and where we had disagreements, the full team resolved the disagreements. So the next slide. We'll show some of the comments, the themes that we identified in terms of family and the impact of the addiction on the family. And there were several of these. The negative interpersonal, and there are lots of quotes that I could have drawn, but I tried to just be selective about this. One was that she has this tendency to be verbally abusive, even with pushing me around and stuff like that. They talked, and again, this is very familiar to this group, I'm sure, disrupted family relationships with anger, aggression, and loss of trust, which I think is a terribly important one. Resource drain. Living with somebody with an addiction can be expensive. This was a parent who said they'd spent at least $10,000 US on programs and rehabs and bonding her out of jail when she'd been drinking. And then they also talked about the inconvenience of having somebody with an addiction. The next slide will show the other themes that came up, the emotional impact on the family, the impact on children, and then things that are, I'm sure, very familiar to many in this group, and Jim Orford was one of the first to identify some of these themes, attempting to control the drinking through trying to reinforce behaviors alternative to drinking. One family member said that he gave his wife money for each day that she wasn't drinking. Legal problems, and then also trying to figure out how to set boundaries and self-care. The next slide will show some of the barriers when we asked them, what would you think about being involved in treatment with your loved one? And the first theme that came up was very pragmatic challenges: time, distance, transportation, childcare, things like that, if they were going to be involved in treatment together. Barriers in terms of the relationship, in terms of the level of disruption in the relationship. Families were very ambivalent about being involved in treatment, and so were patients. When we asked them, they were also very ambivalent about their family member being involved in treatment. And they also, the family members were concerned about how it would affect them to be in treatment. They felt that there was nothing wrong with them, and they thought if they were a person in treatment, that might change the way they thought about themselves or other people thought about them. And the final theme that came up around barriers was that they tended to avoid talking about drinking and thought that, by being in treatment, they really couldn't avoid. And so that contributed to the ambivalence as well. The next slide will show some of their thoughts about being in treatment itself. Then there were some very positive ones. One was that they said, well, it could be really good. When she would come home from treatment sessions when I wasn't there, we'd be able to talk about it. I could say that I'm there for you, and give them more opportunities to open up, and that would be good. They were up, in general, the family members were pretty positive about the idea of being in treatment. There was ambivalence, but they thought on balance they'd like to be involved, but they weren't sure that the identified patient, their loved one, would want them to be involved. When we asked the identified patients, would you like your family involved in treatment? They said, well, that would be very helpful, but we're not so sure our family members would like to be involved in treatment, which really has guided us in terms of thinking about how do you approach people who are seeking treatment, and how do you approach involving a family member, because the ambivalence and the desire seem to be on both sides. Next slide. Okay, so this work was done later than a lot of our couple therapy work, but it still has informed a lot of the way I think about engaging families in treatment together. I'm going to shift now to talk about our alcohol behavioral couple therapy model, which we've called ABCT. There's now a behavior therapy association called ABCT, but we were there first. And if the next slide will show you, the next two slides are going to show the theoretical framework that we've used to guide our work. And there are really two frameworks, I think, that are important. The first is general systems theory. And there are a lot of different approaches to general systems theory. So this is kind of a meta view of that, but really thinking about the fact that individual behavior and behavior change can be understood at multiple levels of analysis. And I think these are really important in the addiction field, because the intra-individual element is really important in terms of biological and neurocognitive changes that can happen with more severe addiction, as well as other co-occurring disorders that people might have. Obviously, the behavior can be affected by proximal interpersonal relationships, as well as larger social systems of work, school, community, friends, and so on. And important to general systems theory is the notion that individuals in a social network really have a reciprocal relationship with each other. And when I teach students about this concept, basically the example I always give is that a person with a drinking problem might say about their intimate partner, well, I drink because she nags. And if you ask the intimate partner, they may say, I nag because she drinks. And it's a perfect circular kind of notion that those influences are reciprocal and not just unidirectional. The next slide will show the functional analytic or behavioral influences on our model. And some of it's very similar to a general systems model, which is that you can understand individual behavior at all these different levels of analysis. But we break it down a little bit more in a cognitive behavioral framework. So we look at environment. I'm sorry, does everyone hear my dog barking in the background? She's very loud and very big and very protective. Okay, so intra-individual and environmental, we look very much at antecedents. Then we look at what are the kind of cognitive, affective, and physiological responses to those antecedents. Then how is that expressed in behavior? And then what are the consequences that maintain the behavior? And we think that change in behavior is motivated by recognizing those negative consequences and wanting to delay those, as well as wanting to increase positive rewards in their lives. And that we want to create incentives in both the proximal and larger social networks that will provide motivation for people to change. The next slide. This is working really well, thank you. So the alcohol behavioral couple therapy model, as I said, is based in these two different theoretical frameworks that really, I think, are harmonized pretty well. This therapy focuses on the primary intimate relationship, and it draws on cognitive behavioral approaches both to the treatment of alcohol use disorders as well as distressed relationships. And I will say we've used it with a range of severity of problems. So I say alcohol use disorder because it's the diagnostic term, but it can be also for less severe alcohol problems. There are three major kind of components to the treatment, and the first is to teach a person, and we've focused primarily on abstinence, although in our more recent work we've not emphasized abstinence as much, but the first major element really is to help people learn how to change their drinking behavior. The second is really to help the partner learn how to cope with the drinking and support change and manage, deal with their own reactions and their own functioning. And the third is to improve the intimate relationship. And the next slide shows you the structure of the treatment. It's an outpatient treatment. We've, up until recently, we've conducted this as a standalone treatment. We've tested it from anywhere from 12 to 24 sessions in length, usually weekly sessions. We have had partners present for all of the sessions. And as a result of that, we've had the sessions being a little bit longer, about an hour and a half in length. And we have treatment manuals that guide the treatment. We have handouts and worksheets for the couple, and have tried to provide structure for the treatment and for the clinicians. Next slide shows you our treatment manuals, and this is these have been out for a while, but we do have published manuals that are available for people who are interested in the treatment. And these are published through the Oxford University Treatments at Work series. The next slide will give you a lot of what we've learned over a series of clinical trials of ABCT. And I've been at this, as you could tell from the introduction, I've been at this for quite a long time. So this is a summary, and I did put some citations down at the bottom for people if they want the presentation and the citations. The first thing we really learned was that addressing relationship issues along with the drinking leads to better drinking and relationship outcomes than just focusing on alcohol. Our earliest study, we had one treatment condition. It was a randomized trial we had partners involved with the treatment from the beginning, but we just focused on alcohol. Then we had a second treatment condition where we focused both on alcohol and partner coping, and the third condition that included the relationship functioning as well. And the results were really impressive in terms of seeing that third condition people did much better. They stayed together, their drinking changed, and they were happier. So all of the things that you would hope would come from treatment. We then took that kind of treatment model, we looked at some relapse prevention elements to try to decrease the relapses that would happen. And the one thing we found from that was that the relapse prevention did decrease the length of the relapse episodes. We also tried combining our treatment with AA and Al-Anon, and that didn't really do anything that was helpful, which was surprising, but that was what the outcomes were. We then started doing some work with women. In our first study, we just compared a couple therapy with individual treatment, and I'm going to show you some of these outcomes because they were kind of interesting. But we did find that the couple therapy was more effective, and even with women who were presenting with other kinds of diagnosable psychiatric disorders. We also, though, found that in that particular study that women with drinking problems really were much more hesitant about being in conjoint therapy than the men. When we did studies with men, we'd do advertisements to try to bring people into the studies, and about half the time the woman would call for her partner, and they would, we'd have a pretty high rate of the people entering treatment. When we started doing studies just with women and we advertised, almost all the time the woman was the one who called for herself. And in one study, we gave them a choice of individual or conjoint therapy. And then there was complicated 2 randomized trials that we did depending on which treatment they chose. But the women who didn't choose the couple therapy they were very hesitant about it for many reasons related to not wanting their partner there, feeling it was their own problem, feeling embarrassed by talking about their drinking with their partner there, and a number of other reasons as well. But the women who chose conjoint therapy wanted to have their partners involved and helpful to them. Okay, then finally, the last big trial that we did we tried combining individual and conjoint therapies for women, and we found that the one thing that worked really nicely with that was that it really enhanced treatment engagement and the number of sessions that people came to. So that's the big overview of our couple therapy outcomes. The next slide will go into one of the studies. just to show you a little bit in a little bit more granular fashion what some of the outcomes were. So this was a randomized trial with 102 women with alcohol use disorders and their male partners. So these were heterosexual couples. About a quarter of the men had either a current or a past alcohol or other substance use disorder as well, so they were not excluded for that. And then they were just randomly assigned to couple or individual treatment. And we assessed them at baseline, post-treatment, and then 6 and 12 months later. The next slide shows the overall outcomes. And I wish I could use the arrow. So if you could use the arrow and follow the red line first, that was the individual treatment. And what you see is that's the treatment phase, and then in outcome during go back please, during the follow-up period, as happens with a lot of treatment studies, this is the percentage of days they were abstinent, and that decayed over the follow-up period. The yellow marks are the couple therapy, and what was interesting is that at the beginning of the couple therapy, the women had less days abstinent, but quickly caught up, and then they maintained their change throughout the follow-up. And when we did a variety of statistics that were looking at those regression lines, we also just compared the outcomes at each month of follow-up, and the asterisks over the month show that those were significant differences at every single month. So we're seeing from this that couple therapy is harder to do at the beginning with people with addiction because you're dealing with the drinking, you're dealing with the relationship, you're dealing with the partner's emotional reactions to this, and so they're trying to do a lot of things at once. But once they kind of get it, they do well, and they really sustain their drinking outcomes. The next slide shows some of the patient treatment the interaction effects that we found. So the upper graph, the black is the individual therapy, the gray is the couple therapy, and this is looking at people who either did not on the left or did have another axis 1 diagnosis, usually a depression or anxiety diagnosis. And this is the percent days abstinent at 18 months. And what we found, which was a complete surprise to us, again, we're comparing individual and couple therapy here, was the women who came to treatment with other psychological problems had more abstinent days by the end of follow-up when they got the couple therapy rather than the individual therapy. We thought it was going to be the opposite, that the couple therapy would do better, or the individual therapy would do better for women who were struggling with other problems at the same time. But what we think is that the couples learned how to work together to deal with problems in general, and that we think that it generalized to other aspects of their lives. The lower figure is looking at women who presented with an axis 2 diagnosis, which was typically borderline personality disorder. And here we found an interaction effect for heavy drinking days at the 18-month follow-up. And again, black is the individual therapy, gray is the couple therapy, and you can see at the follow-up that the women who had these other personality disorders had fewer heavy drinking days by the end of the follow-up. So we've been pretty encouraged by these results. And the next slide should give you a summary, a summary as well as some of the challenges. So overall, we've found over this series of clinical trials, and there are other people who have been and are doing this work as well. Timo Farrell and his group are probably the other group that's done the most work with the conjoint model for alcohol treatment. And consistently across our groups, we've found that the outcomes are very positive when you engage the family member in the treatment. In general, though, couple models have not been adopted widely in clinical practice. And I think there are a number of reasons for this. One, at least in the US, it may be different in other parts of the world, but certainly in the US, it hasn't been adopted as widely as I think it should be. And first, it just doesn't integrate well with a conventional substance abuse treatment program because it takes a lot of sessions, it's hard to learn. Our model has been fairly restrictive in terms of involving intimate partners. One solution that we've been testing, and I'll come back to mention this briefly at the end, is a brief family-involved treatment that can be integrated more completely into a couple therapy, into an ongoing substance use treatment program. But in the interest of time, I'm going to move on to the next section of the talk. So if I could have the next slide, which is looking inside the therapy. And as I said, this is probably one of the more interesting things that I've done as a clinician and researcher, is to really start to listen and say, what actually happens when we have therapy sessions? So the next slide, we'll show you our overall, so we call this study MATES, Mechanisms of Alcohol Treatment Engaging Spouses, and I will thank one of my former graduate students, Mandy Owens, for coming up with that. And it kept us happy to have a name for this project, because it was a tough one. Our goals were really to study what happens in the sessions, to study the impact of the behavior on the impact of the therapist on the behavior of the couple, and then to see how the couple's behavior relates to drinking outcomes. The next slide will show you some of the methodology. We had therapy session tapes from 4 of our studies of ABCT, so we had about 186 sessions, and we had therapy tapes from both session 1 and a mid-treatment session. We transcribed the sessions, and then we coded the tapes using standardized coding systems for therapist behavior, overall specific things that the patients said, as well as a global rating of what they said during the sessions, and similarly, specific utterances and global behavior of the significant other. The next slide will show you the behavior coding system, which really can be broken into 3 categories: positive, negative, and neutral behaviors. Positive behaviors included things like change talk, support, collaboration, giving advice. We thought advice was going to be positive, and providing encouragement or support. Negative behaviors were things like counter change talk, contempt, direct, in other words, telling the person what to do as opposed to suggesting, and confrontation. And then there are neutral behaviors like giving information and talking about themselves. The next slide will show you just what do people talk about. So this is just the mid-treatment session for simplicity. I decided I wouldn't show you everything. Red is the identified patient, gray is the significant other. The codes at the bottom, I just have sort of put a little square around some of the positive codes, which are giving information about drinking, encourage support, that's general or about drinking, and giving advice. And what you see is that they don't really do that much of that in the therapy session compared to other things. The things they do a lot are giving general information and talking about drinking, or just talking about themselves. Those are the bars that are really high. So we don't see lots of positive behaviors. And then if you look to the right, you see a little red square that is around the 2 negative behaviors that we thought would be most negative, the direct and confront. And you can see these are really low frequency behaviors as well. So when we actually started listening to these therapy sessions, we were surprised that how much of the time people are just saying, well, we went to the movies on Saturday, and we went out for dinner first, and we both had like iced tea and that's all really important therapy content, but wasn't kind of the meat that we were expecting. So that was some of the specifics. The next slide will show you the global codes. And this was listening to the whole, like at the end of listening to the whole session, doing a global code on 1 to 5 scales for support, both for the significant others, alcohol specific and general support, for the identified patient, general support. The next slide will show you the rest of the global codes. Collaboration, which is like working together in the sessions, both from the significant other and the identified patient perspective, and then contempt. And the next slide will dig a little bit more into contempt, I believe. Oh, go back, I'm sorry, I took that slide out in the interest of time. So contemptuous is really the extent to which the person is either critical or warm. And at the higher end, this is things like disdain, resentment, sarcasm toward the partner. The next slide, the next two slides will give you some examples of contempt. Okay, so this was session one. The male was the identified patient. The S, you see, CO is contempt code. SO is the significant other. IP is the identified patient. The female says to her partner, "Doesn't matter that Justine's stuck home every day of the week. All she ever does is go to work. Big whoopee shit, and that's how I feel about it." And the male is like, if you were saying you want to go out one night, would I tell you no? She says, "Well, yes, you do. If I go to an effing Tupperware party." "Well, you can shut your mouth. I don't want to hear that kind of language." Well, and then this becomes inaudible. And he says, "I don't want to hear that. I don't like it." And she says, "You wouldn't even be here if I hadn't told you I would come here and support you with this." So that's contempt. The next slide gives another example. It's a little bit more subtle. I'm going to do the first one and then skip down a little bit. But this is a female patient. And this is the patient who says, "Well, as much as he doesn't like me to direct what he eats. I don't like him, and he'll purposely put something in his mouth." And he says, "I don't intentionally eat more." Oh, she says, "If I tell him that he's eating too much or shouldn't eat, he'll intentionally eat more." And he says, "I don't intentionally eat more." And so they're kind of just sort of on the border of discussing and arguing at this point. But when he says, "I don't intentionally eat more," then she really does confront at that point and say, "Oh, yes, you do." He says, "I just eat what I eat and I just eat what I eat and what I want to eat." And she says, "And he'll prove it to me by eating it." So those are a couple of examples of what contempt looks like in a session. The next slide will show you, again, the ratings of contemptuousness are not incredibly high. They sort of trend towards contempt. Here, the other bars, the kind of dusty blue is general support, turquoise is collaboration, gray is contempt, and then the dark blue is alcohol-specific support, and that's only for the SO. So you can see that the contempt isn't super high, but the next slide, we'll start showing you some of the results from this. So the first thing we found that during treatment, couples increased their positive behaviors. Over the course of treatment, they talked less and less about drinking. We found, and as I mentioned earlier, we thought advice would be a good thing, but partner advice in the first session was a clear predictor of poor drinking outcomes, and patient contempt toward their partner predicted poor drinking outcomes. And then finally, the degree to which patients expressed motivation to change predicted better outcomes. So some kind of interesting, like the contempt, we thought it was going to be a problem in terms of outcomes, and it was certainly something that we found very clearly. And the big surprise for us was advice. And if I think about it in my own life, I really don't like getting advice particularly, and I suspect that was equally true for the patients in this study. Okay, the next slide gives you a bigger summary of what we learned from mates. The first thing, as I said, in the therapy, much of what is involved was people talking about themselves and talking about each other. Drinking, not surprising, was a major topic of conversation. The couples didn't spend much time saying positive things to each other. We expected to see more, particularly by the middle of treatment, more kind of affirmations and kind statements. And, you're really making a lot of progress, and I'm really, I feel like we're working better together, and I appreciate that. We didn't hear very much of that. Kind of globally, like the tone of the session was that they were fairly supportive, but it was more kind of a tone than specific things. Contempt in particular was a very clear marker for poor outcomes, and something that for me, in terms of teaching therapists in doing couple therapy, it's an important thing for people to learn how to listen for and learn how to deal with in an effective way. And as I mentioned, giving advice also it doesn't seem to be a good thing. And then finally, therapists actually can enhance clients' commitment to change, and which we know a lot from motivational interviewing. we didn't really think about as much in this context, but it also showed up very clearly in this context. And these expressions of change talk essentially were what things that predicted better outcome. Okay, next slide. I'm coming to my summary and conclusions. I was hoping I could do this efficiently so that we'd have plenty of time for discussion and questions. So the next slide. Let's start kind of at the beginning, going back to summarizing some of the focus group work. As this group knows well, families with members with an alcohol or other substance use disorder experience multiple challenges across like all sorts of areas of their lives. One of the things we learned was that they really didn't understand alcohol and drug problems. In some of our most recent work, which I'm going to mention in passing, we've now just incorporated some information, just straight information about, how do people develop these problems, also trying to decrease the kind of blaming and attributions of intent that family members often make, either, like saying it, and also sort of, I guess, expecting that if they just wanted to, they could change. So really trying to help incorporate more information for families to understand something about these. As I mentioned from our focus group work, it seemed pretty clear that many families would like to be involved in the treatment. They see barriers to it and they're not sure that the patient wants them to be there, identified patient. And similarly, the identified patients want family members to be involved in treatment, but they're not sure that the family member wants to be there. The next slide will continue the summary and conclusions. As I mentioned, partner-involved treatment is more effective than individual treatment in decreasing drinking, increasing relationship happiness, and at least in women, works better than individual treatment, even when the identified patient has other psychological problems. I didn't mention this at all. We did one study where we used the same model with couples where drugs were the primary problem, and we did not get incredibly positive results from that trial, so we're a little hesitant about that right now. I know William Falls Stewart did a lot of work in this area, but his work has been discredited because it seemed fairly clear that he was falsifying data. So we don't have a good database of information about conjoint therapy with where other drugs are the primary problem. We did find that even though I'm a great proponent of a conjoint therapy model, that a lot of women don't like it. But if we combine the individual and the couple therapy, that seemed to be helpful. Next slide. Just is a brief summary of the coding study that we did looking inside the therapy that, and I've already said this, contempt is bad. Overall, couples can be fairly supportive and therapists can influence the outcomes even in couple therapy. And then finally, the next slide or so will give you some ideas about future directions. So the first is, as I said, our model has been a couple therapy model and not integrated, not adopted widely. We started thinking it would make sense to try to develop a more user-friendly family and treatment model. So we've developed a very brief treatment model. It's a 3-session treatment that can be used at any time, integrated into an ongoing treatment program, and it can involve any family member. And it's very, very cut down, trying to figure out how to increase positive interactions, having some behavioral contract for change, and some very rudimentary communication skills. Our results were pretty promising. It was a treatment development study, so we had a fairly small sample. And Julianne Flanagan, who is at the Medical University of South Carolina, is now doing a full randomized trial of this brief family-involved treatment. I think another important future direction in this field is, somebody says thank you and goodbye, thank you for being here, is using technology in support of of these kinds of treatments. So we've done this, I've been involved with this other trial, is way outside of my comfort zone, but working with a person who's very involved with technology and development of smartphones, the smartphone apps. And we've developed a smartphone app for families of DWI offenders. We've done a randomized trial, and our preliminary results there, again, really encouraging and positive. There are some other groups that have been working on developing smartphone apps for treatment seekers and their intimate partners, that's looking pretty good. And there's a group now who's developed they have an online program called Our Relationship, which is a program is for couples in distress. And they have just received funding recently to add in some substance-related interventions into their Our Relationship program. So this will really be focusing on people who have other kinds of relationship distress, but have some concerns about alcohol or drug use. So I think there are lots of other technological areas that lots of potential, but these are three that I wanted to mention. One thing I've not done in my work particularly is focusing on what happened, the family members' outcomes in the context of conjoint treatment. And when Richard and I were first talking about this talk, I was like, I really haven't done enough of that. So that's really important. Some work to combine pharmacotherapies with family interventions or conjoint interventions. Again, Julianne Flanagan has just completed a trial of oxytocin, where she's using the alcohol behavioral couple therapy model and randomly assigned couples to receive oxytocin, the love drug, before the therapy sessions. And she hasn't broken the blind yet, so we don't have the outcomes. But I think that's an interesting area that combining different kinds of pharmacotherapies with family interventions. And then finally, the work is woefully inadequate in terms of diverse populations, sexual minority couples from racial and ethnic minority groups, and so on. So that's really an area that's a huge gap, I think, in the work to date. Next slide. I just always want to acknowledge my grant support from our National Institutes of Health, two of them that have supported us. And then finally, the next slide is, I believe, thank you. Yes, and then there's another slide that just says, and questions and discussion. Looking forward to hearing people's thoughts and comments. Thank you so much.
Thank you very much for this excellent talk and this insight into couples therapy. And so the floor is open for questions and remarks. So you could use Steph already raised her hand, so.
Thank you so much, Barbara. That was fascinating. I didn't realise there wasn't going to be gambling addiction within that. That's sort of what I work in, and I've developed with a gambling addiction charity in the UK, and something very similar. So I've set up an Affected Others service, and it runs parallel with the gambling addicts in treatment. And so I've found so much of this useful, but a large part of work I'm finding to get the gambling addict to willingly want the family member to work alongside their treatment is around education with the family, and also I score them on a core 10. So once I can see that the loved one's anxiety has reduced, they're more open to working together. And I just wanted your feedback on that. But going back to the service that we're delivering, we are finding we can measure outcomes far better. We are finding that the reduction in relapse is massive with having the family involvement, and we have definitely, without a doubt, got faster and speedier recovery. But I thought I'd just ask you this as well. It's quite interesting you speaking, because I'm finding that wives and female partners are very hostile when the males are being very positive in group work that I'm doing, and I just wondered if that's something that you've found as well. The women sort of seem to be very, you're going to pay for what I've lived with, and I just love your expertise on that.
That's fascinating what you've said, and the extension to the gambling area is that's very exciting. Years ago I had a grad student who just worked as a clinician with couples with gambling problems, but I wasn't familiar with your work, so thank you. Two questions. You said a question. You said when the partner, when the identified gambler is positive, you mean when they're talking positively about the gambling? Is that what you mean in the sessions?
Oh, sorry. So yes, and when I'm doing those sort of family sessions, the one that's in treatment is very positive. It's like, I will earn your trust back. I will do this to change. I will do that. And they're far more positive. And I'm finding it's quite difficult because the females in particular are quite resentful in those sessions.
Yes, that is so characteristic of the couple work we've done, both with alcohol and with other drugs. And part of what I try to do as a clinician is to essentially validate the partner's experience. To say, yeah, this has been the significant other. This has been difficult, and you've probably, and I'll often just turn to the identified patient and say, I suspect that you feel in your heart that this is the time you're going to change, and it feels right, and you feel really ready, and you're making changes. But for you as the family member, you've probably heard this before. And it takes a while for trust to come back, and you almost have to take a deep breath and say, I'm going to follow and try to learn from the therapy and be supportive, but I'm going to live as a family member. You're going to live with that anxiety for quite a while, and it's real because this is what's happened, and for the patient then to be able to say to the patient, and this is kind of, because this has been going on for a long time. It's great. I also will say it's great that the two of you are talking and sharing that, because you both have strong feelings about what's happened and about what you want to see going forward. But it's going to take a while. So that's not. That I kind of feel like I can deal with well. When we did our one study with people with other drug problems, the one thing that I never figured out quite how to deal with clinically was sometimes we would be using a functional analytic approach, and we'd be talking about identifying a high risk situation, and it was usually a wife would say that's just an excuse. And it doesn't. He uses drugs and it's bad, and it was really hard to engage them in a different way of thinking, other than like a very judgmental and kind of moralistic one, essentially. So thank you for your question and your comments. That's really exciting work. Okay, other questions?
A brief one in the comment is, you already said that the manual is available, but the further question is whether this is a licensed program and if you need to train as a facilitator to deliver it.
Okay, it's not a licensed program. And I've never done really develop a whole infrastructure for training. There are a number of people around who are well trained in the model who can do trainings, and I'm happy to put people in touch if they're interested in training. But we've written the manuals in a way, the therapist manual in a way that it's pretty step by step, and we have like sample dialogue and things. What can you say, and have a whole section about anticipated problems. And so obviously it takes some learning, and this would not be as true for this group, but for people who've never done conjoint therapy, there's certainly a learning curve.
Okay, and then, well, another question is if Steph Schulten, you asked whether you could have the introduction for training. And Jim also raised his hand.
Okay.
So,
yes. Oh, Barbara, thank you so much. Can you hear me? Yes.
Yes.
Yes. Thank you so much for that talk. I mean, you've got such a wealth of experience to draw on. It's just, you know, it's wonderful to hear all that from you, because it raises, you know, as always, it raises such a lot of fascinating questions. I've just got a couple for now. I mean, one is just, how does it work actually marrying alcohol-focused work and relationship-focused work? I mean, do you one day say, right, we're going to do relationships today? Where we did, you know, we did alcohol last week, we're going to do relations today, or does it naturally integrate together as you go along? So that's one question. And the other question was really following up on this important question about ambivalence. I mean, that's so important, and it's something I must say that I'm very concerned about. That, you know, you've got a wonderful evidence-based treatment there, but if it's not going to be fully integrated into services and taken up in a big way, then we're not having maximum impact. And you're developing various ways, like, you know, smartphone apps and short versions and so on. But had you as part of that done or thought of doing sort of integrating a family member and an identified patient separately sometimes as well as together? Because I know in a lot of services that try and work with families, they do a bit of that. They say, right, we're going to, you know, we need to have some sessions with the, you know, with the spouse or the family member first before they're ready to go in together. Is that something you do as well?
Okay, let's see. I know I have 2 minutes here, so let me see if I can address each of these very quickly. So the first, I guess the first question is, like, what does the therapy look like in terms of the alcohol focus and the family focus? It's the content starts more alcohol focused and kind of slowly moves into more relationship focused, but they're integrated all the way through. You can't be, as a therapist, in the room with two people who have a relationship with each other without doing couple work right from the beginning. So, you know, we try to do a lot of orientation about, like, why are you both here, and how, you know, we recognize as a therapist how much this may have affected your relationship, and also that it's easier to change when you're changing together. So there's sort of like, there's an orientation part to that. But even in the first session, when they start interrupting each other, you know, I'm good on hand signals, and I don't start with them, but I might say, hold on a second, let's talk one of the, let him finish, and I really want to hear what you have to say. And, you know, so you start kind of as a traffic director almost. So there's kind of really rudimentary couple intervention at the beginning, and then slowly, informally teaching them some, like, showing them some kind of simple communication skills. We also have a section fairly early on that really involves couples decision making together about things like, are we going to keep alcohol in the house or not? What are we going to tell our friends? Things like that. So that they're doing some problem solving together, but around couple issues. And we also have some early on, just some simple support things that they can do for each other, or noticing positive things that the other person has done. So it's integrated all the way through. The focus, you know, I'd say the bulk of the focus early sessions is more alcohol focused, but we're doing the couple therapy all the way through. And then your second comment is, I guess I'm not quite sure how to answer it. I think there are, you know, I kind of feel like in the UK with the NICE standards of just say, like, families should be involved, or if that's the standard of care, that helps a lot. And we don't have that in the US in the same way. And I don't know as much about other countries, but I think the the mandating of some kind of family involvement. There are lots of treatment programs in the U.S. that involve family members, but it's a very kind of like Al-Anon sort of perspective of, you have your disease too, and you need to learn how to, let go and take care of yourself and things like that. So it's not really, relationship focused in the same way. I do think the idea of orienting, the first treatment program I ever ran, we used to do it was an inpatient program. We would do an interview with a family member to get some social history and things, but also to get them engaged. And I think like having those individual sessions with a family member to get started can be very helpful also in terms of orienting them and helping them think more about what their role can be. So it's a very inadequate and short answer, but best I can do. I see Richard's hand is up, and I don't know what we do in terms of the time, but I'm okay with continuing. But Richard?
Yeah, well, okay. Firstly, thank you very much indeed, Barbara. That was just marvellous, as I thought it would be. So I'm glad to see that I was right and to hear that I was right. And very wide-ranging, obviously, because you've had such a wide-ranging career. I've got loads of questions. I'm going to confine myself probably to two, although maybe I might chuck a third one in. But they're sort of higher order questions. The first one is, obviously, your ABCT is fantastic and well known, but there are others as well. And in a sense, it seems to me that there's some common themes that run through all this way of working. And they're the three things that you really have brought out yourself about your way of working, which is that you need to work on changing the drinking behaviour or the gambling behaviour or the drug taking behaviour. You need to help the family member learn how to cope and think about how their responses might be having an impact, and also thinking about themselves. And you need to work on the relationship. And all three of those are self-evidently important. So it's great that we've got lots of randomized controlled trials telling us that they're important. But there's one of those things that it's a bit like, do we need a randomized controlled trial to work out oxygen's a good thing? And no, we don't. So I mean, firstly, my question is about this generalizability, and shouldn't we be generalizing much more about saying to everybody, look, guys, these are the three things you've got to be doing. And if you do those three things, you're going to make a big difference. And the details about how you do those three things are perhaps less important than the fact that you do those three things. That's my first question. My second one is about implementation. And it's nice that you know of and realise that it's important about the NICE guidelines talking about your and others' work and couple work being so important. But that hasn't really made a difference in terms of implementation in the UK. Yes, NICE came out 10 years ago or whatever and said, look, this is really good, it's evidence-based work, you all ought to be doing it. And actually most aren't doing it. And I don't think it's only about couples work. I think there's a bigger issue about implementation of evidence-based work into routine clinical practice. I mean, even after whatever it is, 50 years of MI, 40 years of MI work, it's that there's a zeitgeist around MI, and lots of people say, oh yes, we do MI. But actually, I think lots of people don't do MI. They think they do MI, or they say they do MI, but they don't do it in inverted commas properly. And that's just one example. I worry about implementation, and I don't know if you have any thoughts about what we do about implementing evidence-based work into practice. And my third one, I said I might shove a third one in, is just about cross-cultural. You talked about other populations that it needs to be worked on, but I'm thinking about not even other populations, but what evidence do we have that couples work works as well in, for example, Germany? So a European country, but using a different language and with a different culture. How well do these things transfer cross-culturally? Because we know from lots of programs which have very good evidence base in the US, often they don't transfer very well into other European countries, even never mind further afield. Okay, I'll stop there. But thanks again.
Oh, good heavens. Now, I should have kept a piece of paper next to me to write all these points down. But so the first point, which is
common themes.
No, I'm good, I think. I'll probably forget something, but the common themes, I think in 2024, we can say this is self-evident, that these are the three things that should happen. I'm not convinced that it was self-evident. You know, it certainly wasn't self-evident when I started this work or when you started work in this field.
Yeah.
And so I think that it's knowledge that we've accrued over time that at some point things become like, no, duh, you know, we got it. This is what should happen. So, and I think you're right. The principles are the critical part. I think in general in therapy, if we think about principles instead of techniques, we probably do better. And I've often said when I think about motivation, motivational interviewing is great, sounds wonderful and everything. But I've also, have heard counselors in recovery who like really get in a person's face and say, look, man, you're completely destroying your life, and like you've like destroyed your family, and you've been in prison, and what the F are you doing? And you need to and I'm saying this because I care and because I've been there, and that works too with some people. So I think if we think in terms of how like relationships need to improve to support recovery, that's the important question, not like we should use these specific techniques. So I completely agree with you on that one. I'm so disappointed on your second point that the NICE guidelines haven't been implemented haven't been as influential as I was hoping that they would be. And so I think that general, I mean, what is it we say? It takes like 20 years in mental health for something that's been supported in research to actually influence practice. So at least that. I mean, there's this whole new field of implementation science now that is intending to be a bridge between what we're finding in controlled research and what kind of goes on in practice. I have a colleague who's working in that area in the area. She's focusing a lot on motivational interviewing. But I think that we're starting to try to develop some methodologies and techniques or approaches to bridge that gap better. But honestly, I don't know. You and at least you and Jim and I are old folks at this point. And if someone said to me, okay, like you need to be like completely throw out what you've been doing for this many years, and this is what should be done now, it would be hard for me to do that. And I think that we have this like massive inertia in any field as people work in to be able to integrate and do new things. And your third comment, I see I remembered all of them, is that translation to different cultures is as well as diverse populations. But the different cultures thing is really important. When I think about couple therapy, the kind of Western model of relationships is one in which we sort of strive for some kind of an egalitarian relationship, and both partners in a heterosexual couple have agency, and that's sort of a kind of an implicit model. But there are cultures where that's not the implicit model at all. It's a completely different kind of model. I've done some supervision of just straight couple therapy, not with alcohol or drugs, with couples, like immigrant couples to the U.S. From very, very different cultures, and where they're going through this difficult transition where the female partner might be coming from a culture where acquiescence to their husband is the norm, and then they come into the U.S. culture, which is a little more brash, and maybe the woman is seeing, I could be different, and he's like, what? That's not our culture. That's not who we are. So I think you're right. Like our treatments have a set of implicit values in them that don't necessarily translate well to different cultures, to different languages, to different, different cultural and ethnic groups as well. So really, really good point well taken. Thank you.
And as you probably might have noticed in the chat, there are a lot of comments as well, and generally, like always, very, very positive feedback. But I would also like to throw in two questions that appeared in the chat that might, somehow, as Richard just pointed out, for example, guidelines alone are not enough to lead to implementation. But a great question in the chat was, how would you summarize the benefits of your findings to convince members of the drug and alcohol workforce to engage in conjoint therapy? So this might be a bit closer to that. And the second question, which then, of course, if you might motivate the treatment providers to offer this, the second good question is, how do treatment providers engage families in treatment initially, and what are the mechanisms to do so? So this is a more clinical question, because you also pointed out that quite often the spouses are somehow hesitant to join in the treatment.
Okay. Sorry, I just flipped over to the chat function on my screen. So this was the question from Daryl McCleister. How would you summarize the benefits of your findings to convince members of the drug and alcohol workforce to engage in conjoint therapy? Well, that's a really interesting question. I guess I would see the problem is I'm sort of struggling with like talking to providers versus talking to systems. And I think in one sense, those conversations should be at a systems level, to and at a policy level, but certainly at an individual like treatment program level, to find out. And I'm not like a person that tries to like thunk people over the head with stuff. So if I was coming in like to meet treatment program directors or providers to ask about like what their treatment is, what do they do, what role does the family play, have they considered like expanding the family involvement in the treatment, and so like trying to elicit from them some of their thinking first about families, and when I've talked with providers as part of that focus group work, it was really interesting because they were very much, we'd like to involve families, but we don't, first of all, it's too complicated. We don't know how to do it. They also said very pragmatic things like in the U.S. for record-keeping purposes, they couldn't see a family member more than 3 times without having to open a separate medical record for them. So, finding out like how do they already think about families, what do they see as barriers to family involvement. So I would want to engage them first in that conversation, and then provide information and offers of support and training and information to help them move toward, it's sort of like doing motivational interviewing in a sense, to motivate a treatment program and policymakers to engage the families more. And then I guess the second question was this the?
It's about mechanisms to engage the family members in the treatment initially, and how this can be done.
Oh, okay. Yeah. Okay. That's actually the very next one on there. I guess it sort of depends on what the setting is. If you're doing outpatient work and a person comes to you for an alcohol or drug problem, then I start with kind of a soft sell, which is getting to know them a bit, and then saying I really finding out who the family member is who might be supportive to them, and saying, I'd really like to talk with them too. The one thing I have learned is that I used to just say, like, I start with saying, would you like to invite them to a session, or would you invite them to a session? And sometimes they'll say, no, I can't do that. I say, well, is it okay if I give them a call? Then I have to get a release of information. But then I would give them a call and say, as you probably know, your wife has come in to get some help with a drinking problem. And I found this really helpful to get, your perspective as well, or a husband's perspective as well. And would you be interested in coming in, or would you be willing to come in for a session? So again, soft sell, but emphasizing that this would be very helpful. So on an individual level, I usually start that way. Sometimes when somebody's just making an appointment, I'll say, find out they have a partner, say, could you bring them along to the first session at least? So usually once I can get them in the door, I can get them to stay, and talk about the benefits, and also the empathy of what they've experienced has been difficult, and I found working together, we can make a lot more progress. So that's kind of at an individual level. At a treatment program level, I think it's good having just institutional procedures that are routine. As I mentioned I used to run an inpatient and then a day hospital program, and it was expected. Every person had a family member who came in for an initial appointment, and then we would have like a family group that was the families and the patients together. And when we're doing particularly the intensive outpatient program or the day hospital program, we'd have a community meeting the next morning. And there was a lot of social pressure that occurred at that meeting, because people would, we'd be saying like, well, how was the family group last night? And then, somebody would say, so Richard, where was your wife, or where was your husband? And so they kind of sort of created an environment where the expectation was that the family members would be involved. But you had to have the structure first, which was like every person who came to treatment had a family member that was involved as well. So those are a few of my thoughts.
Okay, so this has led to the next question by Steph. How do you get around data protection with sharing contact details?
We use a medical release of information, or a release of information. I can't contact anybody if I was seeing somebody, I couldn't contact a family member or anyone without the person's consent. So I would just do the consent. When we've done blended treatment, and we're actually doing this in the study that Julianne Flanagan is doing now with our BFIT approach, we also spend time in individual sessions with talking with the person we're seeing individually to say what things are okay to talk about from the individual sessions, when your partner comes in, and are there things that you don't want us to talk about? So it's an important conversation to have, to try to figure out how to draw the boundaries around that. So the initial contact, signed release of information, if you're kind of doing individual and family involved treatment, those conversations in the individual context about what can be shared or what couldn't be shared.
Okay, very good. I can see. I think we might continue this discussion for even farther longer. I don't know what if you're already somehow exhausted, or whether.
I can stay for a few more minutes, and then
okay.
I actually do need to move on to other things in my day, but this is. I'm just glancing through thank you for all the positive comments in the chat. I really appreciate those, and I'm glad that people are finding this helpful and interesting.
Certainly. I mean, you can see in the chat. Another question that came to my mind was you told you also included spouses with substance use problems themselves. So I just wonder whether there is, did you have no restrictions regarding including spouses, or because I remember that especially for women with substance use problems, quite often partnership might be more a kind of a stressor because the partner has got a substance use disorder on his own than for males. So how do you deal when both spouses are have got these problems, and probably the spouse not in treatment is less motivated to change his or her behavior?
Yeah, that's interesting, because our early studies we limited it to one person with the identified substance use problem. Excuse me. And then particularly when I started working with women, I said, we can't exclude women whose partners also have an alcoholic drug problem, because we're excluding half of the population, or potentially half the population. So three things were really interesting. When I had the inpatient and then the intensive outpatient program, what we often find was that one person came into treatment and the other we just treated as the spouse or the partner or the family member. And we didn't address, we figured out pretty quickly they also had a problem. But what would happen was, without putting any pressure on them, oftentimes they would enter treatment after the other person was discharged. There was almost like one person was fronting for the couple. So that was kind of an interesting phenomenon. But by not focusing on them, it was almost like it was easier for them to identify that they had a concern. In the outpatient work that we've done, a couple of things have happened. Well, one particularly positive. We've had a number of couples in our work, and then also with Julianne's work, because I've been a co-investigator on her oxytocin study. And what would happen is we would have the second partner that who wasn't the identified patient would just come along and do all the same work, and make changes in their own drinking as well, without being the identified patient. And so we'd almost modify the treatment so that both of them were involved, and we'd ask them both about what was going on and the changes they'd made, and they'd monitor their own drinking and things like that. And so again, I think almost like putting less pressure on them made it easier for them to decide to engage in behavior change. We had, at least one of my studies, we had a couple of people who were firefighters or police officers who absolutely didn't want to be identified as being in treatment, or even though we were this is confidential, they didn't want to be identified as being involved in treatment, and didn't want to seek treatment through their own, because they had employee assistance programs. They didn't want to be identified, so they were deliberate about coming to treatment as the spouse, but wanted behavior change. And then the third kind of thing that happened fairly often was the supportive partner, who clearly also had a problem, almost had to change in order to be supportive to the identified patient. And with some kind of, as the treatment would go along, would be starting to say, I guess I really can't keep drinking this way if I'm going to help her, or if I'm going to help. Well, it was often the male partner. And once in a while, we'd have these really annoying people who would say, and it's just a clinical example, but we had one couple that came in. Woman was the identified patient. She would drink, I think, White Russians, which are pretty high calorie. It's got cream in it and all this stuff. And she was somewhat overweight, and she started decreasing her drink. She stopped, and then they went out for dinner, and he started ordering glasses of wine for her and all. And I was kind of what's that about? And he said, well, I don't mind her drinking. I just didn't like that she was fat. And if she drinks wine, she's not going to be fat. And she had a lot to say about that. So we'd occasionally have these heavy drinking partners who didn't change, but it generated really important conversations in the therapy. So kind of a whole range of stuff, but we're often the structure of the therapy and the content sort of moves the other person, helps move the person in changing the spouses or partners change behavior as well.
Okay, wonderful. Last, very, very brief question. Since we are an international network, of course, we got quite a lot of non-English speaking members as well. And I just wonder whether your materials have been translated into other languages so far.
They have not.
Okay, so I'll be in touch with you because I've been well, flirting since a long time regarding translating it into German, but this will be in touch.
Well, it's very interesting through the Behavior Therapy Association that's U.S. based. One person has been working with, I think, with Oxford University Press on an initiative to more broadly take a lot of their Treatments at Work series materials and translating. So yeah, we should be in touch, and there's a broader effort to, I think, recognition that the world is not English centric.
Wonderful.
So,
thank you so much for this brilliant talk and very lively debate afterwards. So thank you, thank you, thank you. We'll be in touch and hopefully see you again at other AFINet conferences, or again in a webinar in the future. We'll see. Brilliant. So have a nice day, and greetings to the dog.
Great. Thank you so much. Thank you all for your participation and all the really, really interesting questions and discussion. Thank you.
Thank you, Barbara, very much.
Thanks.
Gallus, have you already talked about the next webinar in 2 months' time?
No, actually. So I haven't prepared for that, so I'll hand over to you because you're the master of webinars.
I'll just briefly say that the next one is in 2 months' time. It's on the 17th of July, which is a Wednesday. It's at 2 o'clock UK time, and it's on the invitation to change approach. And it's by a couple who have developed the invitation to change approach in the UK, and they want to talk about their experience supporting families globally, but using the ITC approach. So everyone will be very welcome indeed to come to that. And also, I just wanted to give a big thank you to Eileen Farrar. You mentioned a number of people who have been instrumental in getting this webinar and other webinars on the go, which is absolutely correct. But Eileen has also been very instrumental in doing it. And I want to give a very big thank you to Eileen as well for all the chasing up and following up and everything as well.
Wonderful. Thank you all, and see you at the next webinar.
Bye-bye all.
Thank you so much. Bye.